Hi, my name is Nancy, and this is my YouTube channel on CRPS, also known as Complex Regional Pain Syndrome, RSD, and Reflex Sympathetic Dystrophy. In this channel, we will take a deep dive into CRPS, talking about what it is, how it's treated, and associated illnesses. So stay tuned for more. Hi, today we're going to talk about ketamine treatments. This show is dedicated to my friend and fellow CRPS warrior who passed away July 8th of this year, Brittany Service. Brittany was the kindest, sweetest person I know. She dreamed of becoming a teacher. Even with overwhelming health issues not limited to CRPS, she was able to become a teacher of special needs children. She was awe-inspiring. 2 days before her death, Brittany and I text about this particular YouTube show. She really wanted to be part of the ketamine show because ketamine really changed her life. Brittany will be sorely missed by those in the CRPS community who knew her. This is Brittany and her service dog. Okay, so I want to give you a little history of ketamine infusions. Dr. Robert Schwartzman, who I will refer to as Dr. S, of Hahnemann Hospital in Philadelphia, along with two German doctors, Dr. Peter Rohr and Dr. Thomas Kiefer, designed a study to see if ketamine used in anesthesia dosages could cure CRPS. It was already being used for phantom limb pain in Germany. In September of 2001, Dr. S took two groups of Americans to Germany for coma ketamine. These first two groups, each of two patients, did not have benzodiazepines with their ketamine. Benzodiazepine is a classification of depressant drugs used to treat anxiety, insomnia, and seizures. The first two groups had a period of psychotic episodes after their coma and suffered from horrible hallucinations. In October of 2001, I was the fifth American to go to Germany, along with another patient of Dr. S, also named Nancy, to undergo ketamine coma. Because I had reflux, they decided to intubate me, which is placing a breathing tube into the airway to protect the airway. Going forward after this, everyone was intubated. We were both in the ICU for 6 days of ketamine-induced medical coma. They began using Versed and Ativan with the two of us. Once awake, we were moved to a regular room, did some physical therapy to get us up and moving again, and 2 days later, we were on our way home to the States. Dr. S had taken us all medications that we were on for a CRPS. We returned home on Veterans Day, November 11th, 2001. In November 2001, this is when my intrathecal pump dried up and I ended up in the hospital. Not good timing. Dr. Schwartzman was afraid that their attempts to start an IV on me would undo everything that had happened in Germany. Unfortunately, my port broke while I was in Germany. By the end of December 2001, I started getting my CRPS symptoms back. I was never pain-free, but my pain was greatly reduced. By the end of the study, we knew that ketamine was not a cure, but it was a very effective treatment with very few side effects, the risk versus the benefit. The US would never approve a ketamine coma, and Hahnemann certainly would not as well. In February 2002, a doctor of the other Nancy agreed to do outpatient ketamine infusions on the two of us. Her symptoms had also returned. No one knew what dose to use for outpatient ketamine, so Nancy and I were being experimented on to see what dosage worked best. The Germany study was published. I will put the link in the comments for you. Before and after we went to Germany, cognitive studies were also done, as well as thermography, which we talked about in the diagnosis show. They were compared before and after and published. Dr. S started an inpatient low-dose ketamine program, not coma, and an outpatient low-dose ketamine program with good results for most. Dr. S went on to do a double-blind outpatient low-dose ketamine study. Again, I will put this link in the comments. So think back to what CRPS is show. We spoke about NMDA receptors and neuroinflammation. The N-methyl deasparate, also known as NMDA receptors, are the receptors of glutamate, the primary excitatory neurostimulator in the human brain. It plays an intricate role in synaptic spasticity, which is a neuromechanism believed to be the basis of memory formation, neurotransmission, and the neuroendocrine regulation. NMDA antagonists inhibit the hyperexcitability of the spinal cord neurons. So, what is an NMDA antagonist? It is a class of drugs that inhibits the action of the NMDA receptors. Ketamine is an NMDA antagonist. It inhibits the NMDA. NMDA within the spinal cord changes due to an increase intensity due to noxious stimuli. We know that people with CRPS, many things that are not a problem for the non-CRPS person are noxious to the person with CRPS. So ketamine binds to the NMDA, causing the hyperexcitability to calm down. When the hyperexcitability calms down, so does the CRPS pain. Given all this, ketamine inhibits the increased excitability within the spinal cord caused by noxious stimuli. We now understand how ketamine inhibits the nerve's excitability in the spinal cord. It acts on the centralization of CRPS, unlike many other treatments that only act on one nerve group or a group of nerves, such as sympathetic nerve blocks and spinal cord stimulators. There are two types of outpatient ketamine infusions for CRPS. These are different doses than the use of ketamine for medication-resistant depression. However, many people with chronic pain also have depression. Help with depression is an added benefit. I was able to come off my antidepressants for 10 years when I was getting ketamine. Low dose. This is what Dr. S did. He was a neurologist and not an anesthesiologist, pain management doctor. His facility limited the dosage that he could use. Dr. S obviously felt higher doses were needed for his worst CRPS patients since he sent them to Germany for coma. Low doses considered between 200 over 4 hours and 350 over 4 hours. High dose outpatient ketamine is anything 500 milligrams or over in a 4-hour infusion. First, we will talk about low dose infusions. Most ketamine clinics are run by an anesthesia pain management physician or nurse anesthetist. The ketamine room should have the following: a heart monitor, blood pressure monitor, oxygen sensor, oxygen via nasal cannula, emergency medications for elevated blood pressure, reversal of Versed, as well as resuscitative medications. Most of the time, none of this is ever used, but you want to have it there in case of an emergency. A comfortable recliner or stretcher, and the ability to darken the room. A nurse to monitor your vital signs. High dose outpatient ketamine. Most ketamine clinics are also run by anesthesia, pain management doctors, or nurse anesthetist. The ketamine clinics should have the same things as in the low dose: a heart monitor, blood pressure monitor, oxygen available by nasal cannula, emergency medications, a comfortable recliner or stretcher, and the ability to darken the room, as well as a nurse to monitor your vital signs. The protocol devised by Dr. S is used by other doctors. However, the dose may vary. Later in the show, we will talk to Ursula, a friend of mine who also treated with Dr. Schwartzman, and she will describe her reaction to ketamine. And you'll also hear from Emma, who, even though she has pretty bad side effects from the ketamine, she still feels that its benefits outweigh that. So a loading dose is 2 weeks of Monday through Friday infusions to get a therapeutic level of ketamine in your system. A follow-up set of infusions, commonly called boosters, vary based on your need. 2 days every 8 weeks is the most common, but your physician will determine, based on your feedback, what it is that you will need for follow-up care. Medications that can also be given with ketamine are IV lidocaine, IV magnesium, IV Zofran to prevent nausea and vomiting, Versed to reduce hallucinations and keep you calm, by mouth clonidine, which lowers the blood pressure and helps enhance the other medications, and Ativan to help you stay calm. Zopran to use at home is a very important part of the protocol. Some doctors also use a scopolamine patch to help with nausea and dizziness. Infusion itself. You will take your clonidine and Ativan if prescribed. An IV must be started unless you have an IV port. A port is an implanted IV that is accessed for infusions but can be remained accessed for 1 week. We will do a part 2 of this also today, explaining different IV access. Many CRPS patients, myself included, do not have veins that are accessible for infusions and can remain accessed for a week. I was admitted to Hahnemann in 1999 for IV lidocaine infusion, and in 24 hours, no one could get a regular IV into me. So the resident put in a femoral central line and took me to the operating room where a port was placed. IV sticks can cause CRPS as well as cause spread in someone with CRPS. So multiple IV sticks are never a good thing. After you get IV access, you will be hooked up to a monitor that measures your heart rate, respiratory rate, and blood pressure. You will be hooked up to a pulse ox monitor. The nurse will push the Zofran and Versed. The IV bag may include magnesium and lidocaine in addition to the ketamine. CRPS, ketamine infusions, why do they add lidocaine and magnesium to the ketamine? Magnesium has been shown to lower pain levels in studies. Lidocaine has been shown to lower neuropathic pain levels. Back in 1999, like I just mentioned, I was hospitalized for that infusion. And some doctors add these medications to enhance the results of ketamine alone. Each provider has a different protocol for these additional meds. In addition to outpatient ketamine, it can be done inpatient. At this time, I don't know of anyone doing inpatient. The inpatient protocol is normally done in the ICU. You are hooked up to cardiac monitors and oxygen monitors, and your blood pressure is taken regularly. The ketamine starts at 10 milligrams per hour. It is slowly increased until you have a nystagmus, which is a slight movement of the eyes back and forth. Also, when you report feeling tipsy. The ketamine runs 24 hours a day. You are given intermittent Zofran and Versed, and the length of time that the ketamine is run is up to the individual doctor. There is one other use for ketamine in the person with CRPS. With any surgery, there is a risk of spreading of your CRPS. Most anesthesiologists have worked with ketamine. Ketamine during surgery helps to reduce the risk of spread. You need to talk to the anesthesiologist prior to the surgery. If possible, it's best to have ketamine after the procedure as well. If the surgical team won't do that, it is best to arrange with your CRPS doctor to have outpatient ketamine done after the surgery. I have done this with several different surgeries and have not had spread. So, how does it feel to get ketamine infusion? I'm going to interview several people with CRPS who have had ketamine infusions and will describe their infusions. I have experienced coma ketamine, inpatient low dose, outpatient low dose, and most recently high dose outpatient. What I take with me. I take a pillow and a blanket because it's nice to have. I take music, but I only listen to it while they're hooking me up. Once the ketamine drip starts, I stop the music. Dr. Schwartzman felt that it was very important not to have light or sound while you were getting the infusion, as the brain could react better to the ketamine. I wear comfy clothes. My current clinic requires you to wear a Depends just in case. I have a port. I will go into that in part 2 of the ketamine infusion. I bring a wheelchair to get from the car to the hotel after my infusion, and you can get a second one hand at a thrift store very cheaply. After they push the Versed and Zofran, I usually go to sleep. I rarely hallucinate. The one time that I did, I didn't follow my own rules. I usually turn my phone off the night before an infusion or put it in airplane mode so I can listen to music. I listen to the music while they're hooking me up. And as I said, Dr. Schwartzman said it was important to be in a dark, quiet room to get the most out of ketamine. From time to time, I have to be told to take a deep breath. I have sleep apnea, so I wear my CPAP during my infusions, and they often have to add oxygen to that. I have been told off and on I will open one eye because you see double when you're getting the infusion. And that way I remind myself where I am and what is happening. During the infusion and a short time after, double vision is not uncommon. Once I'm awake enough, the nurse will have me transfer into a wheelchair and take me out to our car. We stay in a hotel because I live too far away to drive daily. I usually go to sleep when I return to the hotel for an hour or two. By dinner time, I'm able to eat a light dinner and hydrate. If I have any nausea, then I will take my at-home Zofran, and my doctor has us wear the scopolamine patch through the infusion time. So as you can see on the left photo where I'm hooked up to the IV ketamine pump, and on the right, you can clearly see the cardiac monitor screen. I'm always hot, so a cool cloth on my forehead feels great. I am hooked up to the cardiac monitor. It also measures respiratory rate. You can see the blood pressure cuff on my arm. The pulse ox is on the opposite side on my finger. This infusion was before I needed CPAP. Today we have Cindy with us, and she's going to talk about her experience with ketamine, which is today's topic. I know you were diagnosed as a child and that you were 11 when you were injured and diagnosed. And we're going to talk to you later when we cover EDS and some other things. But how has ketamine treatment changed your life, and how old were you when you started it?
So I started ketamine when I was 21 years old,
Okay,
and I'm now 30.
right. So, look,
February will be my 10 years
yeah,
with Dr. Hannah.
yeah.
Um,
I met
before,
you right around the same age.
yeah, yeah. Before ketamine, I was addicted to painkillers.
Yeah,
It's kind of just like walking around like a zombie.
yeah.
Um, I didn't have much quality of life at that point in time. I
And then
completely
ketamine
stopped
came into
working.
play.
What?
Then ketamine came into play.
Yeah,
At
then
what
ketamine came
age?
into play, and it's changed my life. I'm off all painkillers. I can actually go and have a quality life. I can go travel. I can have fun. I can hang out with my family and friends and not lay in bed all day. And
And you've
I'm
been able
very
to
thankful
develop
for it.
relationships as well.
Yes, yes. I've made so many friends since starting at Dr. Hannah's office. They really have just become lifelong
Yeah,
friendships.
yeah.
So I'm very, very grateful.
To me, that is the silver lining of this disease, is the
Exactly.
friendships we
Yes.
make. So, as far as what you couldn't do before and you can do now, can you give us some specifics?
Oh, at one point in time, I did use a wheelchair.
Mhm.
I don't use a wheelchair much at all now. Um, I am able to get up and like clean my house or help my grandmother clean her house.
Or cook?
Um, I am able to like actually go and travel. I've taken a couple trips abroad, which has been so nice. Um, and I also have gotten back to swimming. I was kind of thrown into the pool at the age of like 3 or 4 and was like, okay, learn to swim. And I was swimming my entire life, but then I stopped swimming for a while just because it was so bad on my foot and leg. But now I've gotten into swimming again and I'm just so happy about it.
And that's really good exercise for us in the water.
Yes.
Yeah.
Yeah.
Awesome.
I go see Dr. Hannah for ketamine infusions every 6 weeks
Hmm.
for 5 days. Um, so we go down on Sunday and then we come back Friday morning, Friday afternoon.
Yeah. That's amazing. And that keeps you at a pretty good pain level.
Correct. Yes.
All right. Well, thank you so much. Well, that then we're going to go ahead and talk about ketamine. How long after your diagnosis did you first get ketamine?
About a year, maybe a year and a half later.
Okay. And I know that you have some pretty substantial side effects. You want to share with us what they are? And obviously, in spite of the side effects, you're still getting treatment. So you could tell us about that as well.
Oh yeah, the side effects they're pretty awful. Um, I would get violently sick. I have a lot more medication on board now to try and like counteract this, so they're not as
Mhm.
bad as originally necessarily. Um, without the extra meds, but they make me horribly nauseous. I get sick. Most of my body feels kind of numb and
Yeah,
oriented. And this lasts for like a couple days, even after the infusions are over for me. So like I have trouble eating because of it, and it's just they make me so sick and so weak.
right. But obviously, you must be getting a good result to put yourself through that.
Yeah, yeah, they're definitely worth it. I mean, I don't think it feels like it's worth it when I'm getting them. The current like feelings are a bit too strong to like look at the future at that point, but like
Right.
definitely are worth it.
So you're getting decent pain relief from it.
They probably give me about 50% relief.
That's great.
Yeah.
You're the only one that I know and have spoken to who reacts that way. I'm not saying no one else does. I just don't know them. So, all right. Well, thank you so much.